Okay, thank you very much, Isham, to allow me to talk about the topic which is close to my heart and to share some of the data we have about this thing, the huge problem. I don't know who came up with the title. Actually, you just put these words into Google image search and, well, don't do it. On one of the pages, I ended up, why I did that search, just to show you a clinical picture what we are talking about, and it's here. Now that's the disease we're talking about. Those of you who are not clinicians, don't worry, that's the last of you see of that clinical picture. Every time I refer to the actual clinical presentation, we have this nice picture there showing the angry skin. Okay, so the trigger for this talk obviously was the Lancet Infectious Diseases systematic review we published about 6 months ago now about the global burden of this disease. But before we can go into that paper, I have to explain to you what the disease is all about. So VVC, vulvovaginal candidosis, is the infection of the vulva and vagina caused by Candida species. The clinical features are mainly vulval itching, soreness, discharge, vulvar erythema, fissures, and edema. And none of these signs are specific to thrush, to VVC. And that's a big problem. They're completely non-specific, and a number of infectious and non-infectious conditions share these symptoms. So I'm also on the working group of the, was on the PHE guideline for GPs about vaginal discharge, and this is just a summary of what GPs should do about abnormal discharge. And you can see from this flowchart, not to go to the detail, that most of the discharge that patients present with is actually physiological. Some of it is infective, but causes vary from BV to trichomoniasis and chlamydia and gonorrhea. Obviously, there's also non-infective causes and foreign bodies and so forth, and malignancies. But BV and VVC are the most common causes. But if you start looking at, this is the other working group I'm on is the BASH, British Association for Sexual Health and HIV, produces all the guidelines for also sort of broader guidelines for various conditions under their specialty. And I'm on that working group working on the update of the VVC guideline, and we've done systematic lit reviews for that as well, and looked at the sort of other conditions that present very similarly. So these are the symptoms that are shared with a number of conditions. Now, lichen sclerosus is a dermatological condition, like is lichen simplex, and then we have vulvodynia, which is a neuropathic pain syndrome, and then we have eczema, contact dermatitis as a completely different entity, sort of allergy end of the diseases. So if you look at the typical symptoms that we think that define VVC, itch and soreness, discharge and so forth, none of them are specific to thrush or VVC. Another important thing to see about this table is that BV is not on the list. It presents completely differently, so you're quite confused clinically if you can't decide in clinical setting, is this BV or thrush? The other thing is that none of these conditions present with deep pain, so if the patient complains about deep pain, you have to start thinking about STIs, so that's a completely different part of the map again. There's another table about signs, same message, nothing is specific to VVC. So the diagnosis cannot be done based on clinical symptoms. So that's why the guidance always has said and will say again that in the absence of clinical response to appropriate treatment, appropriate meaning even that you have the sensitivity results for that, for the HVS, and you have the right drug, if the patient doesn't respond, you have to still review your diagnosis. Asymptomatic carriage of Candida is common, particularly in pregnancy, up to 40%. So you can get Candida in that sample, but it's just an innocent bystander. And the actual cause for the symptoms is completely different. So that is a very, very problematic background to how to make given diagnosis. The causes for VVC are well described, Candida albicans still being the most common. Couple of definitions, just there are all sorts of definitions going about. So for the UK guidance or the PASH guidelines, we now decided to divide them to two, just to acute VVC and then recurrent. Recurrent is defined by 4 or more episodes in 12 months, and 2 of them have to be confirmed by some diagnostics. And then the recurrent group can be divided to 2 quite different groups, which is really important in clinical setting. Try to tease that out when the patient says that, oh, I've tried this and that and the other, but it didn't touch it, it didn't make any difference. So the question is, did it not really? Did it help at all? Or did it help partially? Or did it help actually properly, but the symptoms returned quickly after the course was over? So those are completely different settings. So microbiological response is a completely different story from clinical response, and getting that clear is important. It is definitely a hormonally driven disease, estrogen-dependent disease. You don't see the thrush or VVC in young girls before their puberty, and you don't see it in postmenopausal women after they stop their HRT. Estrogen changes the secretions locally, favoring lactobacillus growth. Lactobacilli do what lactobacilli can, they produce lactic acid, and that changes the pH from the young girl's neutral pH to the grown-up woman's pH of 4.3 or so. In that acidic environment, none of the other bugs really thrive other than Candida. So that leaves you with that sort of symbiotic relationship. The lowering of the pH allows Candida adherence and colonization, and that's where you are. That's where the rise of the infection comes from. Host responses are, in addition to the hormonal side of it, are important. Neutrophils are really in charge of all the symptoms, all the tissue damage, matrix metalloproteinases, and all the other direct immune responses. That's a lot of studies on that. But interesting side of it is that there are some allergic processes involved as well, and quite a lot of evidence of links with atopy and eczema and rhinitis and so forth. But in general, there are complex immune responses locally. Interestingly, IL-17 pathway is not that important like on other mucosal surfaces. It's a different entity of disease, very different risk factors compared to, for example, oral thrush. And as said already, the source is your own colonization once you get there, so it is not a sexually transmitted infection, and you don't share your Candida, it's yours. Single attack doesn't need any predisposing factors, just being a hormonally active woman, that's it, it's a feature. But recurrent disease is sometimes often associated with some risk factors, diabetes, some immune deficiencies, and immunological dysregulation. So you all seen this curve, Casadevall curve, about the immune responses impacting host damage, the level of host damage. So if you have sort of average normal host responses, the colonization leads to the presence of fungi leads to colonization. But if your immune system is weak, you end up with more damage because of the invasion of the bug. And on the other hand, if your immune responses are strong, you end up with tissue damage because of the immune responses. So these are both scenarios in VVC we see. So we see VVC in patients that are immunocompromised or immunosuppressed, and we do see VVC and RVVC in patients that have a bit of sort of atopy and hypersensitive tendency for hypersensitivity reactions. loads of host factors have been associated with this, and I think the main important one is, it starts with the persistent colonization with Candida. So if it's there, you're more likely to get it. Poorly controlled diabetes, not surprising. Immune suppression, yeah. Any additional estrogen is definitely a risk factor, and that's why HRT is a risk factor. Also, the combined oral pill for contraceptive pill is a problem, and there are alternatives for that. As mentioned already, A to B, eczema, dry skin. Dry skin is always itchy, and it's a damaged skin which is vulnerable to infection. Antibiotics, some deficiencies, maybe. So just to put this into context, I get lots of emails like this. I run as they say, itchy fanny clinic, where I see patients like this. So people contact me for advice. So classical story, pregnant woman has tried everything and nothing helps, and microbiology is trying to do some speciation and sensitivities, but in the meanwhile, what do we do? Where do we go wrong here, or do we, and what are the options? So thinking about this, it sounds like a simple story, you know, just probably resistance, change the drug, pregnant, can't really change, what do we do? It isn't straightforward. So diagnosis really builds on full medical history, but also including hormone therapies or pregnancy status. Hygiene routines, a lot of women wash themselves far too much, soaps, water, all that dries your skin and makes the skin vulnerable. And then you need to know what the exact responses to the over-the-counter treatments have been. Is it partial? Is it short-lived? Or what is it? Culture is not going to be recommended anymore in the acute setting. You have a single episode, you treat symptomatically. If you respond, that response is your diagnosis. But if your symptoms return quickly, or if it becomes a recurrent problem, then you start to do cultures, but the timing is crucial. So there you have to, culture is really used to confirm the microbiological response. Because if towards the end of the treatment course, the cultures are clear and the patient is still symptomatic, you know that those symptoms are not caused by Candida anymore. There is a secondary cause. You can have lichen planus, you can have eczema and thrush that feed to each other. Standard breakpoints, thinking about susceptibility testing, standard breakpoints are really done for blood cultures for neutral conditions, and they are done in neutral conditions. If you do the MIC testing for the azoles, particularly at the pH of vagina, at pH 4, you get at least 3-4 dilution increase in the MIC. So slightly elevated MIC for fluconazole means that it's flatly resistant in reality. And really the most important message is that RVVC cannot be treated without actually examining the patient and trying to get your head around it. Giving advice over the phone or by email is really tricky. So do you need to do any further investigations? How do you actually then get forward, further with it? We say that no additional investigations as such are needed routinely, unless there are other indications. For certain, with RVVC, certain things should be ruled out. So obviously diabetes, just the urine dip is fine for that. Some blood counts, iron deficiency, obviously important to check. I do in my clinic quite a lot of MBL testing because we know it's common. You find undetectable levels in about 5% of the population. I think about 55% of my patients are deficient. It is very common in these women that end up with a lifelong problem. That is helpful psychologically to the patients to have a reason why they have this problem. They are desperate. They try all sorts of magic diets and starve themselves and do whatever the dark corners of the internet advise them to do, and it having a clear biological reason is helpful often. I also always highlight the fact that VVC is not sexually transmitted, and it's not a marker of an STI. So offering an STI screen for anybody with recurrent thrush is slightly misleading to the patient, and it may make them feel dirty and what have they done wrong. You have to do proper risk assessment if there is a need for that. That psychologically can be a bit problematic. Of course, we offer HIV screen to anybody who walks through the doors, but again, you need to really take the history properly. But general management instructions, what you can always do and must always do is that all patients should be provided proper information about skincare. So stop using any local irritants and soaps and wipes, feminine wipes and such things. Soap is not meant for the mucosa down there. And you use emollient creams as a soap substitute, and for personal hygiene, as a moisturizer and as a barrier cream. Those are the cornerstones of everything. If there is a proper emollient cream in place, the patient tolerates pessaries and other things better as well. Reviewing that daily hygiene routine is the cornerstone of everything. Intercourse sex is not necessarily need to be avoided as such. It's not an STI, but women often want to refrain from intercourse, particularly if they have fissures and it's painful. But if there's wish for it and pressure for it, definitely advise for using lubricants. The other thing is about the skin down there needs a bit of fresh air. Avoid wearing tight clothing, non-breathable fabrics or daily panty liners and other things that give you that are a problem for your skin. So the treatment options then beyond any of that, they come in tables as we do, but in summary of these tables, we can say that azoles are first line. Azole resistance in Candida albicans at the moment is still very low globally. But yes, definitely have to remember that oral azoles are contraindicated in pregnancy or for anybody who's at risk of pregnancy or who is breastfeeding. So this requires anybody prescribing any of these drugs to women that are in childbearing age to check that they are on contraception. And that they don't, even they say, well, I'm not sexually active. When finally you treat the recurrent thrush, they may become active, and that's it. There are some, of course, there are treatments for non-nasal treatments available, but in this country all off license. So various unlicensed brands of nystatin and boric acid are available, but comes in packages with Polish and German on them. So you have to make sure that the patient instructions are clear. Boric acid is nystatin we all know about, but boric acid is a broad spectrum disinfectant. pH about the same as vaginal pH is, so it's neutral in that sense for that environment. But it can be slightly irritant and avoided maybe as the first line, definitely. Suppression. Suppressive therapy can and should be used in patients with recurrent disease, and the first line is once weekly fluconazole. Fluconazole becomes very slowly secreted to vaginal secretion, so the one tablet is actually 6 days of treatment. So once weekly is plenty. You aim for 6 asymptomatic months so that the immune responses settle with the time, and only then you start slowly weaning them off, going to once fortnightly and then one in 3 weeks and so forth. If you flare and the patient can't come off treatment, they may need lifelong suppression. Then you go back to the lowest dose that keeps them asymptomatic. Once weekly, clotrimazole pessaries can be used in pregnancy, for example, or people who don't want to take tablets for other reasons. in recurrent disease, definitely avoid antifungal creams because they often are more irritating than the pessaries, and creams often come with hydrocortisone, which thins the already thin mucosa, and that is the part of the problem rather than the solution. Consider taking antihistamines. It's about 10-15% of women that actually can be managed with antihistamines alone with this condition. And don't forget skin care. And if complete control of symptoms cannot be achieved, then consider secondary diagnosis. This is from the Lancet review. This is how you describe, you could visualize what the life as a woman can look like. So the middle part is your reproductive years, and any normal woman has, or 75% of women have at least a few episodes over their lifetime, and the taller bars in there are for episode of VVC, and then the dots underneath are treatments. Now, if you have hormone-related VVC, it often is slightly worse just when you start having your periods or you start on contraceptive pill in your early 20s. Then it settles often, but when you're pregnant, it becomes a problem again. Then it settles, and then when you're on HRT, it becomes a problem again. Some people just have it all the time, recurrently for a year all the time. So when it becomes that recurrent, you start suppressive therapy. It often settles things for the period of suppression. You may be able to come off, and the patient has occasional episodes until it becomes frequent again. Again, you have to start the suppression again. So that's how it's managed. So any further investigations do you need? Well, you have to tell about the HRT associated risk, and it's a balance then in the woman deciding what they want to do. And also you may need to, if the patient is on combined pill, to recommend mini pill or an implant. There's no evidence for the treatment of sexual partners in acute or recurrent VVC. The partner can get a bit itchy and irritate. They can get irritation from the heavy colonization in the woman, but if they wash themselves, it's just irritation. It's like putting pepper on your penis, basically. Just wash it off. It'll be fine. You carry your own candida. She carries her own candida. That's fine. It clears itself. There's no evidence about benefit of yogurt and honey mixes and diets and whatever, unless you like them, enjoy life. And then about probiotics, tea tree oil and essential oils, breathable underwear, very little evidence. So enjoy your garlic and yogurt if you enjoy them, but other than that, not treatments for anything. So now going to the actual systematic review we had, what turned out was a huge problem. So the methods we used were basically doing the three main databases, search for population-based studies from 85 to 2016, and try to identify the prevalence of RVVC. And the search terms are listed there, and the inclusion criteria we had were population-based studies reporting the prevalence of RVVC and in defined population with either a confirmed microbiological diagnosis or self-diagnosis. That second part is tricky, self-diagnosis. But to be honest, there are a number of studies showing that self-diagnosis women make is as good as their GP, because GPs don't have time for doing proper diagnostics. So if they respond to the treatment, that's your diagnosis. But that's a weak point, but had we excluded that, we would have ended up with 0 papers. So exclusion criteria were selected populations, for example, patient screen or reports on STI clinics or GUM clinics, so they are patients going there because of some symptoms. That's a biased population. Or if there was some just about colonization, reports about colonization and so forth. So about 500 papers initially were identified, and sadly only 8 of them finally included into the analysis. And the estimates for the global prevalence and lifetime incidence and economic loss were done based on the United Nations population databases. So this is the research and how we ended up with the 8 articles, lots of sort of poor quality papers or biased papers. This is the grading of the 8 included papers. I don't know if you can see it properly, but if you look at the diagnostics column there, most of the papers actually say that the diagnostics was a questionnaire. This is self-reporting. The ones that are there in the middle, that there was an interview and some culture taken, all of them were in slightly biased patient populations in obs and gynae clinics or STI clinics with some effort of more population-based work. But the point here is that the number of patients actually were quite high, so you end up with about 17,000 women included in these from 11 countries, which is not bad. We used modified grade to mark these and how much weight we put on each of these papers for the analysis. So the numbers, they are huge. So RVVC affects about 138 million women annually, and about 372 million women are affected by RVVC over their lifetime. So at some point of their life, they have a period of 4 or more episodes per 12 months. It's the young women 25 to 34 that have the highest prevalence of 9%. So it's about every 10th young woman that has RVVC. And if you think of the population increase, why did we do the extrapolation to 2030, trying to maybe give this paper as a tool for pharmaceutical companies that, now come on, there is a market there. So if you think that the population increase for patients at risk will increase by 20 million by 2030, and the total number of women with this is going to be 150 million per year, there is a market there. Mapping it out where the high incidence countries are, Central Belt, high population countries, obviously more prevalent. And looking at the prevalence figures, it ranges from about 5% to that 9% in those 25, 34-year-olds. So the burden of the disease, also the economic burden, it was calculated for high-income countries where those questionnaires, the questionnaires were basically telephone potpourri kind of questionnaires asking that what sort of laundry detergent do you use and where do you buy your carrots from, and by the way, do you have any thrush? So it was a completely mixed questionnaire type where you ask anything and everything, where you can't say that patients who replied to those actually selected to do so because they had a problem with thrush. They didn't know it was coming. But anyway, so based on those, they were also asked about their impact, how many days of work have they had, how much money do they spend per month on medications and so forth. So the loss of productivity alone is about 14 billion annually, and it's it really is a massive burden of disease in amongst us, and it's sad that there wasn't one single good study that was done with proper diagnostics, with proper population-based approach, with solid diagnostics that would answer the question. So we really had to push the thinking that, okay, this is a quite solid paper. Anyway, this email Having heard all this, maybe you now acknowledge that my reply is a bit longer. It's not a simple answer. It's a lot of things that can be done, could be done. You start with skincare, you start with clarifying what the response to the treatment was. Should you start suppression? If they responded, actually, weekly suppression might work, and so forth. So the answer is very, very complicated. And really, can't make the diagnosis without examining the patient. Maybe there is some secondary problem there. So that's me. Thank you.